Hi everyone, so I'm Becky. I'm a lymphedema advanced nurse practitioner at the Royal Stoke University Hospital, so Stoke-on-Trent, covering Staffordshire, Cheshire and the surrounding areas, and I've been there since 2002. Natalie?
Yes, I'm Natalie Phillips. I'm clinical manager at Hadnam Healthcare, but I'm also a lymphedema nurse specialist working in private practice down in Oxford. So yeah, very much involved in training, products, everything. So.
Can we get a really quick show of hands out of who is here is a community or district nurse? How many practice nurses? Ambulatory care, dressings, clinics? Vascular or other specialist nurses? And those of you that haven't put your hand up, apart from our esteemed guest from journalism, who else do we have? What other areas?
I'm from industry.
Industry, yeah.
Lymphedema.
Industry.
General nurse.
General nursing, fantastic. So we've got a really nice mix across the board, which
And
is
are you
brilliant.
primary or secondary care?
Secondary.
Secondary care, brilliant.
Thank you very much.
Yep, fabulous.
So we're going to discuss today, this is very much an interactive session that is on utilisation of appropriate skill mix. Can that utilisation within the team decrease work demands? So it's very much a debate. This is the only slide we've got. We have some very nice whiteboard sticky that we got off Amazon, which is really good. So it's really about us having a debate. So we've got a couple of opening statements, but do bear in mind that we both have our own opinions, and what we read out from our statements may not.
We're trying to act.
Yeah, not very good.
Trying badly.
Not very good. So I'm going to start, and my statement is the role of the community team is a complex one that involves many different aspects of care for multiple patients with multiple health conditions. By utilising the skill mix of the team across the nursing bands and ensuring all staff are trained in the fundamental aspects of lower limb care, which should include care of wounds and assessment and the application of compression therapy, will reduce the demands on more senior nursing staff and enable necessary care to be implemented sooner. Who agrees with that statement? Who disagrees? Nobody else is voting.
So my opening
Disagree?
statement is slightly different. Care of the patient with a lower limb is multifaceted, involving all different professions and organisations, and we know that complexity is changing and increasing given frailty, increasing age, increasing obesity, comorbidities, polypharmacy, and the management of the lower limb is extremely challenging, and cascading this to staff levels other than registered practitioners has potential for harm and failure of care. So inconsistencies can arise, poor patient experience, delayed healing, and more importantly, not recognising and escalating red flags, for example, infection or sepsis, and therefore patient safety is at risk.
Who agrees with that? It's that. Are you on the cusp? Interesting.
Aspects that I agree with and some that I don't, so there's a mixture within that.
We are very much going to ask you to do two things during the session. One is to bear in mind everything's hypothetical, so we're going to have to think a little bit. There will always be exceptions to every rule, so we're going to talk generally rather than going, well, I know someone who, well, we can all come up with someone. And the other thing we're going to ask you to do is be a little bit blue sky. So the reality we've got to park at the door, because if we actually work on the reality, we'll just go out and do exactly what we're doing because it's the only resources that we've got. But we're going to talk about blue sky thinking because we believe that there are some realities in there that don't necessarily come across. So that's what we're hoping to achieve for the session and get you guys thinking about that. Perfect. So what we want to do is think about the patient journey with a wound on their lower limb. So we're going to identify the different steps within that journey, and Natalie's going to scribe, and we're going to allocate a patient, a healthcare professional group to that. So be it an RP, registered practitioner, or all, which encompasses any other person, be they whatever level of training, but we're going for all. So First of all, we assume that the patient will rock up and have an assessment. So looking at their past medical history, medications, risk factors, and taking into account a brief social resume and mobility issues. Would everyone agree that that's the first thing we would do? And who would do that in the main part in your work, in your experience?
Registered practitioner.
Registered practitioner, is that the same for everyone? Mm-hmm. Yeah, everyone's nodding. So after they've had their assessment, we would move forward to examination. So we now get down to the nitty gritty, and we would have 3 parts to the examination. There will be examination of the legs themselves, examination of the wound, and investigations. So when we say about examination of the legs, what we mean is touching them, feeling them, looking at them, looking for any signs or symptoms. When we talk about the wound, there would be our wound assessment timers, whatever that might be that you use in your area. And when we talk about investigations, it might be something like a wound swab, or it might be something like a vascular assessment undertaking, an ABPI, TBPI, Doppler, whatever that might be. So for those 3 parts of that journey, what are we assigning? So for the examination and the palpation and the touch of the legs, or looking for signs and symptoms, who would do that? All or the registered practitioner?
I think all should be able to, because...
Okay, but in your area, what happened? Who does that?
So for us, it would be a registered practitioner.
Registered practitioner?
Yeah.
Would most people agree? Yeah. What about the undertaking the wound assessment?
Same.
Registered practitioner, yeah. And what about doing those investigations, a wound swab or a Doppler or whatever?
Swab maybe healthcare assistant.
Okay, so swab we could say all potentially in some areas.
But then the Doppler.
Yeah, so other part, but we can say some of those
Yeah.
investigations might be undertaken by other members of the team. Some of them will need to be undertaken by a registered practitioner. Yeah, okay, brilliant. So once we've done our assessment and we've done our examination and undertaken any investigations we want to do, we would then move forward to a selection of the dressing. Who would do that?
Registered practitioner.
Yep, so the selection and prescribing in some instances it'll be as well, won't it? So that would be the registered practitioner. And then what about the actual treatment pathway? So whether that patient's having reduced compression, whether they're having a leg ulcer hosiery kit, whether they're having a wrap, whether they're having compression bandages, who would make that decision? The registered practitioner. And then the application of that, who would do that?
If it's a stocking or a wrap, anyone.
Yep. So there are,
training.
yeah,
Yeah.
but there are components
Yeah.
that most of you are happy with that some people wouldn't always be led by the registered practitioner. Sometimes in that application it could be. Would everyone pretty much say that compression bandaging is by the registered practitioner?
Yes. Where I used to know.
No, not everyone. Yeah, no, so everyone's quite happy that that could be an all in some places. Yeah,
Either or.
yeah, yeah. So we've got some examples where people have worked in areas or are working in areas where a non-registered practitioner would apply compression. Yeah, and everybody seems quite happy that that would be in a stocking or a wrap, and sometimes with compression bandaging. Yeah, brilliant, thank you for clarifying that. Once we've done that bit, and I know it's hypothetical, I know there could be lots of delays in this and there could be differences for whatever reason, but once we've done that, we would then presumably give advice to the patient about what to look out for, how to wear things, how to do things, what to do as far as skin and everything. So we do that. Who would give that advice?
I think all could do that, yeah.
Everybody happy with that it could be all? Yeah, brilliant, okay. And then off the patient goes and then comes back for review, whatever time that might need to be. Who would do the review or the follow-up?
Registered practitioner.
Is everybody in agreement with that? Bit of hedging a bets that there might be some all in some areas. Are we mainly the registered practitioner? Mainly 1, 2, 3, 4, 5. Yeah, mainly registered practitioner. A little bit of. Yeah. Oh yeah. Sorry. Who says mainly registered practitioner?
You could split review and follow up, perhaps, because review would be the registered practitioner.
Ah, so clever. It's in the wording. So as lymphedema therapists, these words don't mean much to us. So yeah. So that's interesting. So review would be by a registered practitioner. Hands up who thinks review would be a registered practitioner. Yeah. Okay. And hands up who thinks a follow-up could be with all. Oh, okay, maybe the wording is not that clear to all of us again. This is what makes this so interesting.
So we're talking like wound assessments, checking that the treatment's working. that would have to, for us, that would have to be a registered
Most
practitioner.
people, I think,
But
are
if
in
you're
agreement with
follow-up,
that.
as in you need more dressings and, you know,
So provision of
Yeah,
items.
that's kind of
okay.
everyone.
Okay. I think that helps. That helps
Yeah.
for us to clear that up. Okay. So Nat had a couple of questions. One of them was about people being happy to apply, for others to be happy to apply compression and wraps,
First
which
of
I think
all-
we've touched on.
I think first of all is the question of who sees or includes the patient as a key person in managing their care.
Yeah.
So how much of this do you feel the patient should do? Could do? Does do?
a lot more. Probably the application bit down, maybe, and maybe not the review. Self-care. It's difficult, isn't it?
Mm-hmm.
So we want to throw out a challenge to you, and we want you to tell us whether you agree or not. But what we would like to do is look at each of those steps and see where we could do things differently. So we know that there's not enough of us. We know that there's not going to be enough of us because we can't recruit into nursing. We're really struggling to retain really good staff and train practitioners in moving forward. So doing things the way that we do them now is not going to be possible. And this is a very traditional way of working, isn't it? The registered practitioner does all of these things because we're the best person at doing it, because we're second, listening, answering other questions, asking other questions based on what you say. So we are the most rehearsed in doing that. And we can ask questions while we're doing the examination, and that saves time, and then we can do this. But I throw this back to you. There is one section on there that I think, as a registered practitioner, you should be doing. And it's absolutely the most important bit. Can you guess what we think that is?
That's not the assessment, because that leads to
Nope.
everything. No, advice and self-care.
Absolutely. So as a registered practitioner, I would argue that your time is best spent on this for two groups. It's the patient and their carers, and of the all workforce. Because if we develop strategies for our all workforce that supports them to do these things safely and effectively, it won't be the same as you doing it, because you're a really experienced practitioner who will ask those other questions, who will pick up on those cues and or non-cues, as it might be, from our patients. We know that you're really expert in that, but there's not enough of you, and you can't carry on doing that in the way that you're doing it. But if you train the workforce to do the task-orientated working that 20 to 40 years ago we tried to get away from as nurses, but we're still doing because we're the best people to do it, we think. If we can separate out the work that can be done really effectively by other groups, other members of that team, this is where we should be spending the vast majority of our time. Because we're expert at that, and we do that brilliantly, and we achieve really good healing rates, and we're moving forward to do even better with that, with the knowledge and skill set that we've got. But we see that as a plus, that we've achieved everything. We achieve healing, great, done. We've done a really, really good job, we're expert. Unfortunately, what we know is the vast majority of those patients leave because they're healed. They then don't continue to maintain their self-management and self-care. And that's where we fall down, and those become patients again of the future, and again and again. If we spend our time on education and support in line with the Leg Club model, then we will actually promote an expert group of patients. So years ago there was an NHS England expert patient programme where it was to upskill patients to be expert, just like the volunteers that we have within the Leg Club. And it's about supporting patients and their carers to become expert in their condition, so that they follow the principles of long-term prevention of recurrence, long-term healthy legs, and don't end up being a recurrent person on and off the books with wounds and with more complexity. If we spend our time changing the agenda to be their agenda, not ours, because our agenda is to make sure that we have safely documented absolutely everything that we've done. Everything we've said, everything they've said must be documented. We must tick the box to say we gave you all of the risk factors, all of the red flags. We told you how to do this, we told you how to wear that, we told you what to take it off, we told you what to do. We've done our bit. We are so risk averse that this bit we were all so happy to say anyone can do, because it's not important. It's not seen as important. The important bit is to do those things. Immediate and necessary care, where we can, in line with the National Wound Care Strategy and recommendations, which is fantastic. It's changed lots of things. But this group can do immediate and necessary care in the absence of red flags with the appropriate training and the appropriate support if we had this group and they were paid for and we had the ability to do that. But I just want us to start to think differently about this section, the education and supported self-management, as opposed to, as registered practitioners, that's the last bit that we do. It's the quick bit. And then we wonder why patients wear their wraps upside down, they wear a leg wrap without a foot wrap, because we go, we've told you that, we've documented it, we told you. Well, but they didn't hear. It's different to hear and see it. Natalie gave an example earlier about patients filming her putting the compression on so that they can then watch that video back. How many of us use the YouTube resources that are out there every single day? They're brilliant.
When I get a new wrap, I get them to put it on in front of me, and I'm like, okay, now you know how to put it on, I know you know how to put it on.
But that time is not wasted time, and you don't really have that time because you have to do all these other things. But actually, patients who leave their compression hosiery in a bottom drawer because it's for best, if you want to go to the hospital, you know, for when somebody's going to see me, we know that we didn't tell them to do that. They made their mind up to do that because they thought that was a good thing to do. It's not based on wanting to step backwards, but it's about real life and living with that.
And it's also about leaving that in the bottom drawer, is that they've left it in the bottom drawer because they haven't fully grasped the concept of the detriment to not wearing it. So if we're spending that time educating and making sure that patients understand the why to what we're saying for them to do,
I rarely encounter a patient who can tell me why they wear compression or how compression works. They know they've got to wear it, they understand that, they know that I've got to keep this on, but they don't understand how it works. They don't know how it reduces inflammation. They don't understand how their compression affects their vascular and lymphatic system. They don't see a picture or a diagram of their vascular or lymphatic system and somebody explains what happens when you put a stocking or a wrap or a bandage on. There's no concept of understanding that if you're on bed rest because you're in hospital for X period of time, that your legs will improve and then you won't wear your garment ever again because your legs are so much improved. However, you've been home for 3 days and it's horrific and pouring with lymphoria and whatever. But if you understood and spent the time educating about that, and we had resources and information that backed that up, we all know the information and we laugh and joke and go, well, of course your leg's worse, but they don't know that. And actually our time would be better spent educating from our specialist expert knowledge these two groups. We think, but we want to know what you think.
I think we're thinking when we were saying education, anyone can do that. I think that's because we know it's so important that we have to reiterate that all the time and keep reinforcing.
Can I challenge you though as well? And I agree.
Yeah.
I'm here to be naughty.
Yeah.
My challenge on that is we are happy to let anyone do it because it's not a risk. You can't harm anyone by giving information.
But then because we're a specialist service and we've only got one healthcare assistant, she's very well educated.
Experienced and educated, yeah.
So it's slightly, it's
Yes.
always, like you said, not the norm.
But I don't think I think we are generally, in any area, very happy for patients to be given information by anyone.
But a lot of them, they will come and they will say, oh, no, I don't have to wear it anymore, now my wound's healed. And I kind of make it, no, this is a lifelong treatment now.
And we all know that we say that to people. We know we do, but they don't hear us. And one of the things that we're guilty of as registered practitioners is we're 10 steps ahead, aren't we? Because they come in, we look at the way they come in, in and we can make an instant assumption as to whether they're going to be able to wear compression or not, whether they're going to be able to get it on and manage it. We've already made that decision long before we've even discussed that with them. We're looking at the wound and you kind of know what you're going to do. You've already made a lot of things that you're going to do. You're looking at kind of what have I got, what we can do today, what can we do, what do we want to do, have we got a delay in practicing because we need to get a Doppler done. What you've made all of those things just by seeing that patient. Yes, okay, you'll go through that with them. But what we do as well is we tell people things as we're doing stuff. So as they're getting on the bed, we're going, so what we're going to do is this, and then we'll do that, and then, okay, we're just going to do this now, and then, yes, so we'll do that, and then that. And then we tick a box going, yeah, I've told them all of that.
But they're thinking, I'm having this done to me. So they're not necessarily taking in the information that you're passing on to them.
What I tend to do is, whenever I get a patient in for their first assessment, I always make sure I explain why leg ulcers happen, and I don't mean this in a detrimental way, but I kind of really dumb down, demedicalise that. And some patient told me the other day, well, I've never heard it explained that way, and it totally makes sense. Because the valves in the vein, I call them doors. And I say your veins have doors in, and they're doors that swing shut. In a healthy person, they close completely, and in somebody that has existing they don't completely, they go shut. And she went, oh my God, that makes so much sense.
Absolutely.
That makes so much sense. And now I'm thinking of doors, not closing. And I'm like, yes, I think of your valve.
And
like
my
that.
challenge, going back again, is we don't then give information
So
for them to take away to do that.
Lovely.
Good.
I think it's a Legs Matter one,
Yeah.
actually, and it's got the picture.
Yeah,
of
the
that.
valves.
Yeah.
Yeah. And I think in specialist areas that probably is
Yes,
the case.
you're
I think
absolutely
within the
right.
lymphedema service, we've got the time to do that. In general areas of practice, that's very different. And I think we might say things, but we don't necessarily have the information to back it up, because it's only when the person leaves you that they're then left to go, I know they said something about that, but I haven't taken that in. And how many of us healthcare professionals, when you're a patient, you're talking about dumbing stuff down, I don't ever say that I'm a nurse, because as soon as you say you're a nurse, they say, well, you know, don't you? You know, I don't. I want you to tell me in a way that I can understand. I don't want you to tell me in a way that you think I will understand, because I don't. And that really means that for our patients who've got no medical training, you take that back again. You want something that's talking about things that is something you can picture and understand totally, because that's what we want, and we've already got a specialist level of knowledge that they haven't got.
We also send out the leaflets, all the information leaflets before they come. So what will happen when you have a Doppler? What is
So that's
concussion?
pre-information.
Yes.
Now that's another area of care that we're really interested in getting your advice and information on, about preventative care. So we know that we're a reactive health service. We don't meet patients until they've got a problem, do we? We never get the healthy population, as it were. So where does our skill mix come in with saving work demands for us if we think preventatively? Has anybody got any ideas of things that we could do with our teams, with our healthcare professionals, to save work demands for us using a skill mix?
Lots and lots of education. So if they see a little swollen leg, rather than waiting for it to become a wet leg, try and do something about that. But it's
And
really
who's that
important.
education aimed at?
So district nurses,
Fine,
practice
okay.
nurses, healthcare assistants.
Yep,
within
so
those
the
teams.
general
So
nursing
yeah.
population,
I mean,
yeah?
the only people we don't cover is nursing homes.
Okay.
But everybody
Where the
else-
vast majority of patients
Yeah.
are.
They
with
took
you.
that away from us.
Yeah, we know,
So
we know,
I'm
we know.
like really struggling.
Yeah.
We just have to ignore them.
But that identifying of champions, that identifying of stakeholders is really important. So as a specialist service, again, it's a bit easier to do. But in general practice, so be that as a community nurse, district nurse, be it as a ward nurse, it's about finding people who are on the same wavelength. So we have found, as an organisation of the British Lymphology Society, so lymphedema practitioners, we found that pharmacy colleagues are very helpful. And actually, if you as a practitioner in your own area visit a couple of the local pharmacies and ask them what information they give to patients with leg conditions, you can work with them because they are desperate for that information. Our pharmacists display a poster now that we've asked them to put up. So if anybody comes in with a leg problem, that they talk to the pharmacist. They have these lovely little rooms they can go in and talk in confidence, and they will actually show a signposting to the patients of what they should do and what they need. Pharmacies are the first port of call now for many patients. You know, you can't get in at the GP, it's really hard. Pharmacists are getting asked more and more and more questions. And lower limb care has never been their baby. It's never been something, you know, other than I've perhaps got a bite or athlete's foot. It's never been something that would you know, where patients would go. And actually what we're finding is pharmacy colleagues are desperate to have that information and will work with you to display information and signpost patients. So it's well worth finding those stakeholders. Social prescribers, you know, if you can get in with your social prescribers, if you're lucky enough to have any in an area, they are amazing at signposting people to the right area. There are carers, as we all know, social carers who are brilliant, who at identifying lower limb problems and will champion lower limb care. So it'll start out that they meet one patient who's been to a specialist service, and then lo and behold, another 10 patients are getting that care because it's been seen. And I know that's not for everyone, but it does work in some areas. Can we look at some of the social care groups in your area to try and get hold of people to educate them and do some of this? It's simple changes in your area that can make a big difference. Those champions, those people of interest would be really good.
And then I suppose looking at the teams as well, so within your team, the skill mix within your team, and we discussed this earlier, looking at those things that we're very wanting to do as nurses because it's our role. Well, actually, our non-registered practitioners could already triage those patients that are due to come in and do the social mobility and past medical history and even parts of that assessment, which then those things that you do in terms of examination, you've got all your answers there ready. So it almost saves that time as well.
And your visible hands-on eye-to-eye contact with your patient that you're doing during your examination is then talking about what you're seeing and what you're finding and what's important to them, rather than trying to fit in smoking cessation, trying to look at risk factors, trying to look at, oh, you had this operation, you know, and your foot's never healed from then, or something like that. All of that could be there for you. It might mean that you work differently. The patient may need to actually leave before you make a decision about what's going to happen, but that they move to another member of the team to have their immediate and necessary care. So actually you can still be doing the bits of prescribing that needs to be the registered practitioner, but it's just about thinking to work differently because we don't have more resources. We don't necessarily have access to more members of staff, and we're not necessarily going to get specialists coming in behind us. You guys are the trailblazers and can make a difference, and if you can provide that education and training to the right groups, using algorithms and flow diagrams to reduce risk, to identify factors, to protect our patients and their carers. That's what's important. As a registered practitioner, you're the only person that can do that. There's nobody else can do that and give that education and shore that up.
It
But
allows
we can
you
work differently.
to drive best practice.
But that could come in with what my colleague was saying about, you know, sending stuff out to patients beforehand. It would be very easy to send them out a risk assessment form, and then you're getting how it is from them, so you're empowering them.
Yes.
So before they come, you've already got a tick box, and within that, that's going to highlight to you the level of expertise where that patient needs to go
So
to
there's
from
two
the very
areas.
beginning.
Yeah, two areas of triage.
Exactly.
Again, there's triage
Exactly.
from the healthcare professional
Yeah.
who may be a non-registered practitioner, but there's also a triage from the patient
Yes.
Exactly.
of what's
Find
important
out.
to
So
them.
we send out quality of life questionnaires
Yeah.
prior
Yeah.
to seeing patients. So
That's
You've
very
already got
much more
that.
difficult on a community and district nursing
Yes.
caseload.
Yes.
We don't have that opportunity
No.
necessarily,
No.
but there is an opportunity for, if there are laps or hubs where calls come in and are then triaged, a lot more work could be done in those areas, because often you walk in blind to a patient in a room with very little information, and you're literally working with whatever you've got in front of you at that point in time. But I think the important bit is about the agenda, and that's our agenda. And yet the patient and carer's agenda can be very different. And if we spend more time on that, rather than trying to get that bit done, we will get better outcomes and better results in the long run. I also wonder what we were saying earlier about the investigations, where we were saying there were certain things that other members of the team can be upskilled to undertake really effectively. I think that that's something that we know works in specialist areas where you've got good support for non-registered staff and you're not on your own. You're usually in a clinic setting. That makes a big difference. When you're on your own in someone's home as a non-registered practitioner, that's very, very different. And the level of support is very different for that person. There's going to need to be much more barriers to safety and to care, both for the individual healthcare practitioner and the patient as well. So we do have to slightly look at different groups. It's not as easy as it being one model or one style fits all.
However, there was an area in one of the other groups where the non-registered healthcare professionals are performing Dopplers and ABPIs, and giving that and looking at those red flags, and then giving that information to those that look at prescribing compression. So it's that, if we've got the information and we oversee the interpretation of it.
And that was a healthcare assistant at GP, several GP surgeries in one area. So they were undertaking their vascular assessment by a non-registered practitioner. Any red flags from that or any readings that were inconclusive were then sent through to a registered practitioner. But actually, there was a very large percentage of those patients that were able to move forward on their journey without any significant hold-ups. And yet, a lot of areas work so historically that it has to be a registered practitioner that undertakes the task, whereas actually it only needs to be a registered practitioner who undertakes the interpretation of the results. And if you're already aware of the patient's risk factors, which you should be prior to undertaking the vascular assessment, then actually you should already be able to make a guess, an educated guess, and then if there was anything outside of that would raise issues. I think it does rely on experienced, educated team members, absolutely, but there's no reason why we can't grow those and grow our own, and use the patient in that as well. So of course a patient can't undertake their own vascular assessment, but they can tell you if things change.
And a patient, would you let a patient apply a compression bandage or change a dressing?
Yes, absolutely.
We're not using the ball.
Oh, do it again. We're ready. We're ready.
Would you allow a patient to change a dressing or apply a compression bandage?
Yeah, well they do. They get sent out with them.
As long as they're taught properly.
Yeah. And that's really, really important. That Becky works with children and they're taught to self-bandage.
Or mum and dad, depending on the age, but everybody self-bandages. Yeah.
So it's really important that patients are involved in that, in managing.
It's also, isn't it, a question of breaking down barriers within the system of that's not my job or that's my job. Again, because that does exist, isn't there, within the echelons. So that's something else.
I think the most important part of that is that it's the patient's life, not no one's job. It's their life, it's their expectations, it's their loves, it's their goals, it's their hopes, it's their dreams, and we're just a very, very tiny part of that can come along at a really important time, can't it, where everything can seem so overwhelmingly difficult to manage. And actually, if we can be that beacon, that light to provide that education, actually all of those things are really important. Of course, people want the management, want the treatment, want to improve, want to get well, but there's something about getting it right first time, that GERT, that every contact counts. We talk about it, but do we actually mean it? Because what we mean by that generally is trying to get those healing rates improved. And of course that's massively important, it's not the only thing by any means. And that's where the LegPath model is so perfect. You've got two documents. You've got the Legs Matter 10-point plan for harm, really important. It talks about the omission of care for lower limb, so it's not good enough. It is harm where care is not provided. It's a really good document also to flag up if any of you have the ability to speak to your divisional nurse, if they have a question and answers, if there's any opportunity, flag it up. I guarantee you they'll know what their question pressure ulcer rates are. I guarantee you they'll know what it costs them, and I guarantee you they'll be able to tell you who their infection prevention lead is and works with on pressure ulcers. I guarantee you they won't be able to tell you anything about the lower limb at all. So flag it up to them. The other document you've got is the Ned Club Manifesto for Change, trying to reduce postcode lottery for our patients, which is so important. Thank you all very much. We have some sweeties for you.
Oh yes, we do.
I've only got one packet left.